How should we pay for primary care? There is broad agreement that the current payment system isn't working. We have a severe shortage of primary care physicians due to low payments and high administrative burdens, and patients aren't getting good care. But what payment system will solve those problems? To answer that question, we need to be clear about exactly what is wrong with the current payment system so we can fix the parts that are broken without destroying the parts that are good. Then we need to determine the right method of payment, the right amount of payment, and how to ensure that high quality care is being delivered. And last but not least, we have to actually implement the better payment system. The first step in designing an appropriate payment system for primary care is understanding the economics of primary care. Consider a hypothetical primary care physician. How do they spend their time? Let's assume the physician works about 10 hours a day and they spend 9 hours of that time on patient care activities with the rest spent on practice administration. About 20% of the 9 hours will be used for activities related to patients who aren't visiting the practice that day, such as reviewing lab test results and approving prescription refills. A lot of time is spent on administrative tasks required by health insurance plans, such as obtaining prior authorizations for tests and medications. This large amount of time is important because the physician is not paid directly for these follow-up tasks. They are assumed to be covered by the payments for visits the patients made to the practice. Because so much time is spent on follow-ups to previous visits, the physician only has about 7 hours left to actually see patients in visits. If we assume the physician would like the ability to spend up to 30 minutes on each visit, the physician will be able to see 2 patients every hour and a total of 14 patients during the day. A 30-minute visit does not mean that the physician is spending 30 minutes with the patient because part of the time has to be spent charting, sending orders, etc. The amount the physician is paid for the visits depends on whether it is a new patient or an existing patient and the complexity of the issues being addressed during the visit. On average, at Medicare payment rates, the physician would likely be paid about $87 for each of the half-hour visits. Based on these assumptions about visits and payments, the primary care practice will receive about $305,000 in total revenue during the year. Does that mean the primary care physician is making $300,000 per year in salary? No, because the physician first has to pay the staff in the practice, such as the medical assistant, receptionist, and any staff or contractors that do billing for the practice. The revenue also has to pay for rent and utilities, the electronic health record system, insurance, supplies, and other expenses. These expenses are generally proportional to the number of physicians. Studies have shown that there really isn't much in the way of economies of scale for practices with multiple physicians, and in some cases their expenses are actually higher. In most primary care practices, more than half of the revenue is used to pay for practice staff and expenses, not to pay the physician. The physician gets what's left, which in this case is only about $100,000. That's not enough for a physician to pay off medical school debt while also paying for a mortgage and raising a family. And it's a lot less than primary care physicians actually make. So how could a primary care physician be paid more? The only way is to see more patients for shorter times. Instead of seeing 2 patients per hour, the physician could plan to see 3 patients. That will allow the physician to see a total of 20 patients per day after factoring in the increased time that will need to be spent on follow-ups from previous visits. The average payment for these visits will be lower because the physician can't address as many issues in a shorter amount of time. However, under Medicare payment rules, the highest hourly rate is paid for a 15-minute visit, so the physician does better financially with short visits. On balance, seeing more patients for shorter visits results in a significant increase in the revenue for the practice. The higher revenue allows the physician to receive a higher salary, but this is still less than the average $250,000 salary primary care physicians are currently paid. How would they get paid more than this? The only solution is to work longer hours. If a physician does their charting and other activities in the evening, they can increase the time available during the day for visits. More hours during the day for visits means more visits per day. and more visits per day means more revenue per year. Now the physician is getting a more competitive salary, but they're working 10 to 11 hours a day to get it. But the primary care practice only gets this much revenue if every hour of the day is filled with patient visits, and that means it will be impossible for a patient to get a same-day appointment if they need one. If the primary care practice leaves slots open on the schedule to accommodate urgent needs, the practice will lose money, $20,000 per year for one open slot per day. The lower revenue means a lower salary for the physician because all of the other expenses in the practice are fixed. What would happen if the physician agreed to see patients by telehealth rather than coming in person to the office? Prior to 2020, the physician couldn't be paid for seeing patients through telehealth. So if the physician saw 20% of patients through telehealth, the practice would lose 20% of its revenues. That would cut the physician's salary by 1/3. The physician can't see more patients to make up the loss because their schedule is filled with visits, and telehealth visits generally take as long or longer as do regular visits. That's why Medicare's decision to begin paying for telehealth visits during the pandemic was so significant. It gave primary care physicians the flexibility to have visits with patients in their own homes without bankrupting the practice. If the physician spends 10 hours per day and sees 3 patients per hour, they can receive a competitive salary under Medicare payment rates and pay all of the other practice expenses. But can the patients get high-quality primary care from this practice? If the physician is seeing 23 patients every day, 250 days per year, they have nearly 6,000 visits during the year. Based on typical visit rates for both younger and older patients, this means the practice probably has about 2,500 total patients. There are 3 types of things the primary care physician should be doing for these 2,500 patients. One is ensuring that they receive evidence-based preventive care. Second is diagnosing and treating acute problems such as illnesses and injuries. And if they have a chronic disease, helping the patient manage that condition as effectively as possible. One study estimated that the physician would need to spend an average of about 40 minutes per year per patient to provide good preventive care. Another study estimated that about half of patient visits were for acute care needs, so the physician would have to spend an average of at least 20 minutes per patient per year on acute visits. A third study estimated that a physician would need to spend an average of 2.5 hours per year for each patient with a chronic condition to make sure they were getting the care they needed. So if 40% of the patients in the practice have a chronic disease, that would average out to about 1 hour per patient per year across all of the patients in the practice. If you add that up, multiply by 2,500 patients and divide by 250 days in the year, you find that the physician would have to spend over 20 hours every day in order to provide good quality care, not the 10 hours that we assumed earlier. That's actually an underestimate because it assumes only short visits for acute needs and no time to keep up with the latest evidence about appropriate care. So it actually would require more than 24 hours a day to do it right. A lot of the preventive care and chronic disease management activities don't need to be performed by a physician, and they could be delegated to a nurse if the primary care practice had a nurse. But even if there were a nurse and the physician did delegate a lot of the work, the time demand on the physician would still be unreasonably high. 16 hours per day for patient care, not 9 or 10. The only solution is for the physician to manage fewer patients in total. If the physician had 1,250 patients instead of 2,500, they could provide high-quality care in a 9 to 10 hour day. However, that assumes that the physician hires a nurse so that the appropriate tasks could be delegated. And unfortunately, the primary care practice can't afford to do that. Hiring a part-time nurse would increase expenses for the primary care practice, and if the practice only had 1,250 patients, it would only receive half as much in revenues. The net result is that there would be no money left to pay the primary care physician at all. You can see this unfortunate trade-off between quality and compensation here in the words of a primary care physician from Cleveland some years ago. She said she was seeing 20 to 25 patients per day, each with multiple problems to address, and also spending a large amount of time on follow-ups to visits. She tried to keep up by working late at night and on weekends, but wasn't able to do everything her patients needed. So she hired a nurse. There was no extra money to pay for the nurse, so the physician had to cut her own salary to ensure that her patients received good quality care. This is one reason why so many physicians are leaving primary care. In fact, based on the economic analysis, you can see there are at least 5 major problems with primary care today. Office visits are short. The physician's day is completely filled with scheduled visits. Many patients receive poor preventive care. Many patients receive poor chronic disease management. And primary care physicians are overworked and underpaid. These problems have significant negative impacts on patients. If the physician can't spend adequate time with the patient is less likely to be diagnosed accurately and more likely to receive unnecessary tests and medications. If the schedule is full, patients won't be able to see their physician when they have an acute problem and will likely go to an urgent care center or emergency department instead. If patients aren't receiving good preventive care and chronic disease management, they're going to be sicker. If primary care physicians are overworked and underpaid, we're going to have too few of them, or they will be forced to work for large health systems that are willing to subsidize their salaries. These problems also hurt the nation's economy. Businesses are spending too much on avoidable healthcare services, and their workers are missing work both because they aren't healthy and because it takes too long to get healthcare issues resolved. Moreover, evidence shows that when primary care physicians are employed by health systems rather than working in independent practices, utilization and prices for testing and specialty care services goes up, which increases the cost of health insurance. Most people blame these problems on the fact that we pay for primary care using a fee-for-service system. But paying fees is not the problem. The problem is that we don't pay any fees at all for many of the services a primary care practice delivers, and the fees we do pay are inadequate. As shown earlier, the amounts paid for visits actually penalize physicians for spending more time with patients. Moreover, fees are only paid for office visits with physicians. There are no fees at all for outreach to patients to encourage and assist them in getting preventive care, and no fees for time spent by nurses educating chronic disease patients about how to manage their condition. Perhaps the most dramatic example of this is in telehealth. Prior to 2020, patients could not have a visit with their physician from their own home because Medicare and most health plans wouldn't pay for it. That changed almost overnight when Medicare and other payers started paying fees for telehealth services. Patients were suddenly able to get a service they needed because there was finally a fee that paid for it. So we don't have to throw out the entire fee-for-service payment system in order to improve primary care, but we do need to fix the problems with the current version of fee-for-service. For example, we need to pay more for visits with primary care physicians to address new acute problems, so the physician has time to properly diagnose the condition and prescribe appropriate treatment. We need to pay primary care practices to deliver proactive preventive care and chronic disease management services. Those services should be continuous, not just when a patient happens to make a visit to the practice. So there should be one fee for a month of care, not separate fees for individual services. The payments have to be large enough to cover the costs of delivering high-quality care, but they should also be flexible enough so the primary care physician can use a team of staff to deliver care in the most effective and efficient way. It is clear from the earlier analysis that payments need to be bigger than they are today. But exactly how much should we pay a primary care practice for preventive care, acute care, and chronic disease care? The answer is that the payment amount should be based on what it actually costs to deliver those services in a high-quality way. It's not enough to say that we're spending more on primary care than in the past, or that a certain percentage of healthcare spending is going to primary care. What matters is whether the payments are adequate to cover the cost the primary care practice incurs in delivering high-quality care to its patients. So how much does it cost to deliver high-quality primary care? We can estimate that by using the time estimates described earlier for the physician and nurse for each of the 3 types of primary care services. Applying the salaries and overhead costs of the primary care practice to the time estimates for each service results in the amount the primary care practice would have to spend to deliver each type of service to its overall panel of patients. The amount spent on acute care is the highest because it is the activity that's delivered almost exclusively by the primary care physician, whereas a portion of the preventive and chronic disease care can be delegated to other staff. Next, we need to translate those total costs into cost per patient so we can ensure the practice gets the right amount of money regardless of the types of patients it is caring for. Since preventive care is a continuous service, the costs will be spread out over the course of each month. Since every patient should be receiving preventive care, the $111,000 in total cost averages out to $7.40 per patient per month. Acute care is only needed for those patients who have an acute problem, and patients who have more acute problems will need more time from the physician. Consequently, the acute care costs are divided by the number of acute events during the year, and the average cost per event is $141. Chronic disease management is a continuous service, similar to wellness care, but only a subset of patients receive it. On average, the cost is $30.60 per month for each patient with a chronic disease. Those estimated costs can then be directly translated into appropriate payment amounts for each of the three services. In other words, the primary care practice should be paid $7.40 per month for each of its patients to cover the cost of prevention and wellness care. The primary care practice should be paid $141 each time it provides diagnosis and treatment planning for a new acute problem to cover the cost of that service. And the primary care practice should be paid $30.60 per month for each of its patients with a chronic disease to cover the cost of chronic disease management services. The monthly payment should only be paid for patients who explicitly enroll for these services. The practice can't deliver these services successfully if a patient doesn't want to receive them, so the practice needs to ask the patient if they want to receive the services in advance. The patient would enroll with the practice, not with the health plan. This is very different from the attribution systems that Medicare and other payers have used in some of their payment systems, where a primary care practice can be assigned a patient even if the practice and the patient have no relationship, while the practice is often not assigned patients they do provide care for. The acute care fees would pay for a visit, but it would not be restricted to office visits the way traditional fees have been. The practice could address acute problems via telehealth if that is the most appropriate means. Moreover, the payments would only be for new acute problems, not for problems related to a chronic condition. The chronic condition management payments would support any visits related to the patient's chronic conditions. Although the standard payment amounts would be appropriate for most patients, it would make sense to pay a higher wellness care payment for a patient who had just been discharged from the hospital or is recovering from a serious illness, since the patient will require more time and attention from the primary care practice. This is similar to the transitional care payments that Medicare now pays for such patients. It would also make sense to pay higher amounts for chronic disease patients in two circumstances. First, when the patient is initially diagnosed with a chronic disease, the physician and other practice staff will need to spend a considerable amount of time educating the patient about how to manage the disease and making sure that the prescribed treatments work properly. Less time will then be needed in subsequent months after it is clear what treatments and management approaches work well for the individual patient. Second, some patients will have characteristics that make chronic condition management much more complex, either because the patient has multiple chronic diseases or because the patient has other characteristics such as a disability or lack of access to transportation. This approach to payment ensures that during any given month, the total payment the primary care practice receives for a patient is based on the primary care needs of that patient during the month. A healthy patient with no acute problems will need relatively few services from primary care practice, so the payment for that patient should be small. But if the patient has an acute problem, they will need a lot of time with the physician to ensure the problem is diagnosed and treated properly, and the practice will need to be paid adequately so it can spend that time with the patient. A patient with a chronic condition will need more time and services from the practice than a healthy patient, and a patient with a complex condition will need even more time, so the payments need to reflect those differences. This is a patient-centered payment system for primary care. The payments are based on what each patient needs. The primary care practice is not paid more simply because it provides more services. This is a very easy payment system for both the primary care practice and any health plan to implement. A small number of new billing codes would be created, one for each of the individual types of payments. The primary care practice would then submit these billing codes each month for each patient who received the service, and the health plan would pay the appropriate amount for that code. For example, the practice would bill code XX010 every month for each patient who had enrolled for wellness care. And if one of those patients had an acute problem during the month, the practice would bill for both XX010 and XX020 for that patient during that month. Many people object to creating new billing codes because they have been led to believe that there is something inherently bad about fee-for-service payment. However, under patient-centered primary care payment, the new billing codes would replace a larger number of existing billing codes. With a few extra codes needed to allow higher payments for complex patients, transitional care, etc., there would only be 6 new codes for the 3 categories of primary care services, and these 6 codes would replace over 24 existing billing codes used in the Medicare program. How would this new payment system work for the hypothetical primary care practice discussed earlier? Let's assume that it hires the part-time nurse and it only has 1,250 patients, so the physician can provide high-quality care to every patient during a reasonable workday. If we assume that all the patients enroll for wellness care, the practice would receive $7.40 each month for each patient, generating $111,000 in total revenue during the year. If we assume that the patients have acute care problems about 1.25 times per year on average, the practice would be paid $141 for each visit to address those problems, and that would generate an additional $220,000 in annual revenue. Finally, if we assume that 40% of the patients have a chronic condition and enroll for chronic disease management, the practice would be paid $30.60 per month for each of these patients, producing an additional $184,000 in revenue. Altogether, the practice would receive $515,000 in total revenue for the year. That is enough to pay all of the practice expenses and to pay the physician an appropriate salary. An employer or health plan that is paying for primary care services will want to know what their cost will be. This will depend on the characteristics of the employees or members they are insuring. If you assume that their employees or members have an average of 1.25 acute problems per year and 40% have a chronic disease, then the employer or health plan would be spending about $34 per month on average for each employee or health plan member. You might ask whether it would be simpler and easier if the payer just paid $34 per month for every patient, rather than paying separate fees for each category of service. It might be simpler, but it wouldn't be better, because it would no longer be a patient-centered payment system. To see that, let's look at 8 hypothetical patients who might be receiving primary care from the practice. 3 of these hypothetical patients have no chronic disease. 2 have 1 or more acute problems during the year, such as a back injury or fever, while 1 is completely healthy all year. 3 of the patients do have a chronic disease, and in addition, they vary based on the number of new acute problems they have that are unrelated to their chronic disease. 1 patient has a very complex condition and also has acute problems during the year. The final patient is diagnosed with cancer during the year and begins receiving most of their care from an oncology practice. What is the cost for the practice to deliver primary care to each of these patients? Based on the analysis performed earlier, we can estimate the amounts. For example, the cost for the completely healthy patient will only be about $89, whereas the patient with a complex chronic condition and 2 additional new acute issues will cost over $1,100. The patient with cancer may be getting very expensive cancer treatment, and the oncology practice will be spending a lot of time with the patient. But the primary care practice will not be delivering many services to the patient, so the cost of the primary care practice's services will be relatively low. These cost differences all make sense. It will cost more to deliver primary care to patients who have more acute issues, and it will cost more to deliver good primary care to patients who have chronic conditions. However, if the employer or health plan simply paid $34 per month for every patient, the practice would receive exactly the same amount of revenue for every patient. This is exactly what happens in capitation payment systems, which are nowadays being referred to as population-based payment systems. The result is that the employer or health plan is overpaying for the healthy patients and underpaying for the patients with higher needs. This only averages out if the primary care practice continues to provide care for all the same patients. If the primary care practice begins caring for more high-need patients, it would lose money. Medicare and other payers have tried to solve this problem by risk adjusting the monthly payment amounts. Does risk adjustment enable payments to match the cost of primary care? The risk adjustment system used by Medicare and all of its payment systems is what is called the Hierarchical Condition Category, or HCC system. It assigns a risk score to each patient based on their age, sex, and the chronic conditions they have been diagnosed with. For example, in the HCC system, a 66-year-old male with no health problems would be assigned a risk score of 0.308. The HCC system only adjusts for chronic diseases, so if the 66-year-old male had pneumonia or experienced an injury during the year, the HCC risk score would be exactly the same, even though the primary care practice would need to spend more time on the care of a man with an acute problem than one without. If the man was diagnosed with diabetes in the previous year, he will be assigned a slightly higher risk score. The primary care practice would also need to spend more time with the man to help him manage his diabetes, but the risk score is not based on the amount of time the primary care practice spends. It is based on the total amount Medicare spends on all services the patient receives. If the man with diabetes had other problems, such as limited income, which made it difficult for him to afford his medications, or lack of access to transportation, which made it difficult for him to see the doctor, the primary care practice would likely need to spend a lot more time helping him manage his diabetes. But his HCC risk score would be exactly the same, because things such as income and transportation access are not assigned points in the risk scoring system. If the man didn't have diabetes but was diagnosed with cancer during the year, his risk score wouldn't change because HCC risk scores are only based on diagnoses assigned during the prior year. The primary care practice probably wouldn't be spending more time with him because he'd be getting care from an oncology practice. However, the following year, his risk score would double because of the cancer diagnosis the previous year. It's not clear whether the primary care practice would be spending more time on the man's care. That would depend on whether he was still receiving cancer treatment or not. But the HCC score depends only on what diagnoses the man has, not who is providing care for those diseases. So if you risk adjust the primary care practice's payments based on the HCC system, there would be higher scores for patients with chronic conditions, but not for patients with acute problems, and the score would be higher for some patients with a health problem as being managed by a specialty practice. So for these 8 patients, the risk-adjusted capitation amounts would likely still differ dramatically from the relative cost of the primary care services, and the practice would still be underpaid for higher need patients. In contrast, the patient-centered primary care payment amounts are specifically designed to match the differences in the time and costs of primary care services for different patients, so there is no penalty for serving higher need patients. This enables patient-centered primary care payment to automatically risk adjust the revenues for the primary care practice based on the number and types of patients it is caring for. For example, let's take the hypothetical primary care practice shown earlier with 1,250 patients. It is being paid with the patient-centered primary care payment amounts discussed earlier. Those payments generate the annual revenues discussed earlier, and the revenues are sufficient to cover the cost of operating the primary care practice, including the nurse, other staff, and a reasonable physician salary. What happens if a smaller percentage of the practice's patients have a chronic disease? If the patients are healthier overall, then the practice can take on additional patients. The payments for each type of service would be exactly the same, but the mix of revenues the practice receives would be different. Less revenue would be coming from the chronic condition management payments because there are fewer patients with chronic conditions. But there will be more revenue for wellness care and acute care services because there are more patients in total receiving care. Overall, the total revenues remain sufficient to cover the practice's cost, so there is no significant impact on the practice from providing care to healthier patients. Conversely, if a higher share of the practice's patients have a chronic condition, then the practice would need to have fewer patients in total in order to spend adequate time with the higher need patients. Although there are fewer patients, the higher revenues for chronic condition management payment offset the smaller revenues for wellness and acute care, and so the practice is still able to cover its costs. If the practice has patients who experience acute care problems more frequently, the practice will also need to manage fewer patients in total because it will be busier with acute care problems. But because the practice is being paid based on the number of acute problems it addresses, it once again receives adequate revenue to cover its costs. The number of patients that a primary care physician can care for depends on the types of patients and their needs. Under the patient-centered primary care payment system, a physician with higher need patients can manage fewer patients rather than working longer hours and receive adequate payments to support that. Most of the costs of the primary care practice are fixed in the sense that the practice spends the same amount for the physician, nurse, medical assistant, rent, etc. every month, regardless of exactly which services the practice delivers. So the practice needs to receive enough revenue to cover those costs every month. Under patient-centered payment, the payments automatically adjust to maintain the same amount of revenues when the practice adjusts the number of patients it manages based on the relative intensity of care they need. For example, if a practice has more total patients because fewer of them have chronic diseases, the total cost of operating the practice will be the same, and the total revenue should be the same. If there are fewer patients because more of the patients have chronic conditions, the total cost of the practice will still be the same, and the revenue should also stay the same. And if there are fewer patients because they have more frequent acute problems, the revenue under patient-centered primary care payment will adjust so it is sufficient to cover the cost of operating the practice. Patient-centered primary care payment also ensures that payers are paying their fair share of the cost of primary care, but also no more than their fair share. For example, let's take two hypothetical payers or employers, each with 100 patients who are receiving care from a primary care practice. A higher percentage of the patients insured by payer B have a chronic condition, and they also have more frequent acute problems unrelated to their chronic condition. Each payer would pay the exact same amount for each type of service the primary care practice delivers to the patients. However, payer B would spend a lot more on acute care and chronic condition management because more of its patients have acute problems and chronic conditions. As a result, payer B would spend more than 2.5 times as much for primary care on a per member per month basis as payer A. But the difference is due entirely to differences in the characteristics of the patients, not because the payers are paying different amounts for the same services. Patient-centered primary care payment may sound as if it's more complicated than proposals for population-based payments because it uses 3 different types of payment rather than a single monthly payment for each patient. But that's because the complexity of population-based payment is hidden in the risk adjustment system. Moreover, the risk adjustment systems that are typically used fail to adjust for major differences in patients, such as the number of acute problems they experience and non-medical factors that make care management much more complex. Patient-centered primary care payment can be implemented automatically through the standard billing and claims payment systems every health plan and primary care practice uses, whereas population-based payment systems require complex attribution and risk adjustment systems that most health plans cannot implement, and that increase administrative burdens on primary care practices. Finally, under population-based payment, the primary care practice receives the same payment whether it addresses a patient's acute care needs or not, so there is the potential for patients to receive less care than they need. In contrast, under patient-centered primary care payment, the primary care practice is only paid for acute care if it actually delivers acute care services. Medicare and some other payers have tried to solve the problems with a purely population-based payment system by creating what is referred to as a hybrid payment system that continues to pay fees for office visits in addition to monthly payments for each patient. This is actually more complicated than patient-centered primary care payment because it uses 2 completely different approaches to payment for every service. Under the hybrid payment systems, the practice still has to bill for every visit, including visits related to preventive care and chronic disease care, and the health plan still has to pay for every visit. But the health plan also has to create the same kinds of attribution and risk adjustment systems described earlier in order to pay the monthly payments for each patient. In contrast, everything in patient-centered primary care payment can be implemented through standard billing and claims payment systems, and there would be far fewer billing codes than under the current system. Although the hybrid approach was supposed to give primary care practices more flexibility about how to deliver services, the practice's revenues are still dependent on how many office visits are made with the physician. In contrast, under patient-centered primary care payment, the practice is paid for delivering appropriate care, not for delivering services in a specific way. Many primary care practices lost a considerable amount of revenue during the pandemic because patients were unable or unwilling to come to the practice to receive services. Some people have claimed that population-based payment and hybrid payments would solve this problem. However, the systems used to calculate population-based payments only attribute a patient to a practice if they have made office visits, and a practice has no control over which patients will be attributed to it. Moreover, the hybrid systems also continue to base much of the practice's revenue on visit-based fees. Patient-centered primary care payment provides much more predictable payments for the primary care practice, since the practice knows exactly how many patients it has enrolled for wellness care and chronic disease management, and it has the flexibility to deliver acute care to the patient in whatever way works best for the patient without requiring the patient to come to the office. Patient-centered primary care payment would also be much more effective than other systems in addressing disparities in care, since it pays higher amounts for disadvantaged patients if they have more acute problems and more complex conditions, and it provides flexibility to deliver care in different ways. What about behavioral health care? There is growing recognition that behavioral health services need to be integrated into primary care, not delivered separately. There are two basic models for doing this. One is called the collaborative care model, and the other is called the primary care behaviorist model. Both approaches require the primary care physician to have a staff member with the training and skills needed to deliver basic behavioral health care services to patients. In the past few years, Medicare and other payers have begun paying fees for these services, but the current fees are problematic for a number of reasons. It may be difficult or undesirable to assign a behavioral health diagnosis to a patient in order to bill for the fees, and there may not be enough patients in an individual practice receiving the billable services to cover the cost of the staff needed to deliver those services. In addition, it's important for the primary care physician to be able to do a warm handoff to the behavioral health specialist immediately following a visit with the physician, and that can't be done if the behavioral health specialist's schedule is full delivering services that generate revenue. A better approach, the patient-centered approach, is to pay the practice a monthly fee for every patient who is enrolled in the practice for wellness care, not just for those patients who are actively receiving behavioral health services. The amount of the fee should be based on what it will cost the practice to employ staff with the necessary training and skills. Based on calculations similar to those shown earlier for other services, a $4.25 payment per month for every patient in the practice would likely be adequate to support the cost of delivering integrated behavioral health care services. In addition to the services already discussed, there are a number of minor procedures that primary care physicians can perform in the office. In general, it is desirable for them to do this when possible, both because it avoids the need for a patient to make a separate trip to a specialist or hospital, and because a procedure delivered at a hospital would likely be far more expensive. The best way to support this is to pay a fee for each procedure that is based on the amount of time the physician will spend performing the procedure and the cost of any equipment, supplies, or medications needed. Similarly, it would be more efficient if patients could receive routine lab tests at the primary care practice, both because it would reduce the time they have to spend getting the test and also enable the physician to act immediately on the test results. The best way to support this is to pay a fee for each test that is based on the cost of performing this test in a primary care practice. Even if the cost is slightly higher than in an outside lab, the savings in time and improvement in care quality would likely justify the higher cost. The amounts shown here are just estimates based on typical primary care practice costs. Higher payments will be needed for practices that are located in areas with higher costs or where it is more difficult to attract staff. In addition, if a payer wants a practice to spend additional time with patients or deliver additional services, the payments would need to be higher to allow that. Although adequate payments will give primary care practices the ability to deliver higher quality care, patients, purchasers, and payers will want assurance that if practices receive adequate payments, they will deliver higher quality care. Current value-based payment systems evaluate the quality of a primary care practice's services using a small number of narrowly focused quality measures, such as the percentage of patients who were screened for colon cancer and the percentage of diabetic patients whose hemoglobin A1C level was above or below 9%. However, these measures completely ignore many of the kinds of services that patients need and receive from primary care practices, particularly acute care services and care for a number of common and important and chronic diseases. The solution to this is not to add more quality measures, because the measures that are being used today are fundamentally flawed. They use a one-size-fits-all definition of quality, ignoring the many situations where a patient should not or cannot receive the services required by the quality measures. Because of the problems with the quality measures, no one expects that any primary care practice could ever achieve 100% performance on the measure. However, that means it is also impossible to determine whether a practice has a higher performance level because it is delivering higher quality care, or because it happens to have patients that can more easily conform to what the measure requires. Moreover, measuring whether quality is good on average does not assure any individual patient that they will receive high quality care. We need a much better way to assess quality. A patient-centered approach would be to expect physicians to use clinical practice guidelines in order to ensure that each patient receives the evidence-based care that is appropriate and feasible for that patient. If the physician doesn't deliver evidence-based care and doesn't document the reasons for deviation, then the primary care practice shouldn't be paid for the corresponding service. In addition, physician practices should use a patient survey, such as the How's Your Health survey, in order to proactively identify when their patients are having problems, and also to determine whether the services the primary care practice is delivering are meeting the patient's needs. How would this work in patient-centered primary care payment? The physician practice would not bill for a wellness care payment during a month if a patient was not up to date on all recommended preventive services. If the practice documented that the patient was unable to obtain those services, for example during a pandemic, or the patient was unwilling to do so, then the practice could be paid, but otherwise it would not be paid until it had helped the patient get the necessary care. If a patient made a visit to the primary care practice for an acute problem, the physician would be expected to follow evidence-based clinical practice guidelines for diagnosing the symptoms and treating any identified problem. If the physician billed for the visit, they would need to attest that they had followed the guidelines or that they had documented the reasons for any deviation. Similarly, the practice would only bill for a month of chronic condition management if it followed the relevant guidelines relevant to the patient's condition. The practice would only bill for a monthly behavioral health care payment if it had appropriately trained staff at the practice and if it was conducting appropriate screening of patients and appropriate interventions. The practice would only bill for performing a procedure if the procedure was appropriate based on current evidence-based guidelines. And the practice would only bill for performing a lab test if the test was appropriate for the patient's needs. As an example of how much better this approach is in assessing the quality of care, let's look at the most commonly used quality measure today, which is the percentage of patients with diabetes who have a hemoglobin A1C level over 9%. We'll examine several hypothetical patients who received different kinds of primary care during the year and how their HbA1c level changed as a result. And we'll look at how their quality of care would be evaluated under current pay-for-performance and value-based payment systems, and how quality would be evaluated under patient-centered primary care payment. The first patient is a new patient who joined the primary care practice at the beginning of the year with a very high HbA1c score. The primary care practice provided all of the appropriate evidence-based care to the patient during the year and successfully reduced their HbA1c to 10% by the end of the year. Under standard pay-for-performance systems, the practice would be penalized because the patient failed to meet the arbitrary 9% standard in the quality measure, even though the patient experienced a more than 20% improvement in their blood sugar levels. In contrast, under patient-centered primary care payment, this would be viewed as good quality care because the practice had delivered all evidence-based care and the patient had improved as much as possible. The second patient starts out the year with a very good HbA1c level, but the practice fails to deliver evidence-based care during the year, and the patient's HbA1c worsens to 8% by the end of the year. Under typical pay-for-performance systems, this would be treated as good quality care because the patient's HbA1c was still below the arbitrary 9% standard, even though it got significantly worse during the year. In contrast, under patient-centered primary care payment, this would be viewed as poor quality care. Finally, the third patient starts out with a relatively high HbA1c level. The practice attempts to use evidence-based treatment, but the patient cannot afford to take the necessary medications. Instead, the practice uses alternative approaches to help the patient, focusing on diet and exercise, and is able to keep the patient's HbA1c from worsening. Under typical pay-for-performance systems, this would be viewed as poor quality care, because all that matters is the HbA1c level, and there is no adjustment for the patient's inability to afford the medications. In contrast, this will be viewed as acceptable quality under patient-centered primary care payment because the practice had documented that the patient was unable to use evidence-based treatment and the practice used an alternative approach that was feasible. A careful examination shows that patient-centered primary care payment is preferable to all other alternatives in terms of 4 desirable characteristics of a payment system. The primary care practice should be paid for delivering proactive care and non-visit-based services, as well as in-person offices with a physician. The payment amount should be set at levels expected to be adequate to cover the costs of delivering high-quality care. Each patient should be assured of receiving appropriate high-quality care in return for payment. And the primary care practice should receive additional resources and flexibility to help patients who have higher than average needs or who face barriers in accessing services. In addition, patient-centered primary care payment is the only payment system that avoids 4 undesirable characteristics of a payment system. There is no financial penalty for keeping patients healthy. There is no financial penalty for delivering or ordering all services the patient needs. There is no financial reward for withholding necessary services. And there is no financial penalty if spending increases or a patient experiences a poor outcome for reasons beyond the control of the primary care practice. It is clear that we need a better way to pay primary care practices, and patient-centered primary care payment is superior to all of the alternatives. Unfortunately, there are some significant barriers to implementing a better primary care payment system. One of the biggest barriers is that health insurance plans are generally unwilling to implement better payments for primary care. The reasons are financial. Spending more on primary care will reduce a health insurance plan's profits. Even if the plan is simply paying claims for a self-insured employer, the plan will not want to incur any additional administrative costs to implement a new payment system. In addition, health plans benefit from being free riders. Primary care practices are not going to deliver care differently to patients based on the type of insurance they have. So if other payers pay differently and the primary care practices improve care, the members of the non-participating plan will also get better care, but the plan won't incur the extra costs. Many people have looked at the Medicare Innovation Center as the mechanism for reforming primary care payment. But CMMI can't change primary care nationally. It can only create short-term demonstration projects in limited geographic areas. Moreover, the projects it tests are required by law to reduce Medicare spending. And the higher the payments to primary care, the less likely it is that total Medicare spending will decrease within the time frame of the demonstration projects. The goal of primary care is to improve patients' health, not to reduce total spending. So it is unlikely that CMMI will ever be able to create a truly desirable primary care payment system. So how can we overcome these barriers? First, self-insured employers and other purchasers should stop using any health plans that will not implement patient-centered primary care payment. Self-insured employers spend as much money on health care each year as Medicare does, and they spend even more if one factors in the cost of lost productivity for workers. If patients have a choice of insurance plans, they should choose plans that implement patient-centered primary care payment. In addition, where patients have a choice of health plans, primary care practices should refuse to contract with the plans that don't change the way they pay. Congress should create a patient-centered primary care payment for original Medicare beneficiaries and allow any primary care practice that wants to participate to do so. Congress needs to ensure that the payment amounts for primary care are adequate without requiring cuts in payments to specialists. Those Medicare beneficiaries that choose a Medicare Advantage plan should only choose a plan that implements patient-centered primary care payment. Primary care practices should refuse to contract with the plans that don't. Finally, states should require that Medicaid managed care organizations implement patient-centered primary care payment, and the Centers for Medicare and Medicaid Services should grant approval for states to do this. In states that do not use Medicaid MCOs, the state should make patient-centered primary care payment available to primary care practices. You can learn more about patient-centered primary care payment in a detailed report that is available at www.paymentreform.org. There is also an executive summary and answers to commonly asked questions available. All of these reports can be downloaded free of charge.